Good afternoon, ladies and gentlemen. First, I want to thank the organizers for inviting me to this webinar. I'm Jörg Taubel of Regimen Pharmacology and the Regimen Research Institute, and today I would like to discuss our latest research and put this into context both in terms of early phase studies such as TQT studies and IQT studies, as well as what our findings might mean for patients. I have no interests to declare in relation to this work, and these are the usual disclaimers. Let me begin by saying that effects of interference with glucose regulation or regulatory mechanisms on cardiac repolarization are not really well understood, particularly when these effects are off target, and that is something I see in my practice very often. There is little recognition that hyperglycemia may be an independent risk factor for arrhythmias. The CSRC has published this white paper in 2015, and it describes issues affecting the conduct of TQT studies and their interpretation for antidiabetic medicines. It is therefore maybe not surprising that hyperglycemia does not really feature in this publication. Developing antidiabetics, hypoglycemia is usually a far greater problem. And if you look at this document, these 2 pages deal with clinical and preclinical findings from literature. You can see only that small paragraph in the green box is dedicated to hyperglycemia. If you do a search on PubMed, then you will also find that there are many papers which deal with hypoglycemia. I found about 90 just in one search. And if I then switched the search around for hyperglycemia, I only found 54. So what does that tell me? Clearly these studies that are published there are in the main clinical outcome studies. So I made a short list of 6 papers which tell us that hyperglycemia is associated with poor clinical outcomes and that a prolongation of the QTc interval is at least involved. The question, of course, is, are these adverse clinical outcomes a result of interference with repolarization via a mechanism that prolongs QT, or is this just a concomitant observation because, of course, you find this concomitantly with many pathologies? What interests me is whether hyperglycemia is a distinct milestone patients cross on their path to arrhythmia, and is this QT prolongation caused by excursions of blood sugar, be this in diabetic patients or be this drug-induced, where it's an off-target effect. Is this a standalone cause for developing arrhythmias and potential fatalities? My interest is in mechanistic studies, shedding light onto this black box that there is between a correlation of a biomarker or symptom and the clinical outcome on the other side, but where we have no real mechanism with which we can explain how we transition through this black box. Hyperglycemia is not a risk factor we recognize when prescribing drugs known to prolong QT. In this recent review from 2017 by Van Dale, hypokalemia is right on the top of the list. It goes on to factors we're all well aware of, such as age, pre-existing heart disease, etc., and female sex. Diabetes, which of course also includes states of hypo and hyperglycemia, appears not to be highly correlated, but neither are channelopathies really very high up on this list. One of the best mechanistic studies I found in literature is this paper, which tests type 1 diabetic patients in a 2-hour hyperglycemic study where they reach blood glucose concentrations between 17 and 18 millimoles per liter. But they get a clear QTc signal of 20 milliseconds. And you can see that at the 2 columns in the middle. Unfortunately, the study is fairly short, and we have no measurements of insulin and potassium during that 2-hour clump. We only have it at the beginning and the end. And that's unfortunate because this would be very interesting data. But I now take you to the bottom of this slide because there's an even more intriguing finding. Because these are not diabetic patients, these are healthy volunteers where insulin secretion is blocked by an octreotide somatostatin agonist infusion, leading to the same degree of hyperglycemia. So about 17, 18 millimole, not very high. But these volunteers have a much more pronounced effect on QTc. They have double the effect of the type 1 diabetics. They're around 40 milliseconds. Now, 40 milliseconds of QTc prolongation, ladies and gentlemen, that's a statement. So, obviously, octreotide is not used for treatment of diabetes. So this is an off-target effect. And it's not a very common one, but it occurs. If we look at the glucostasis regulatory system, it is of course complex, and we don't really have much definitive knowledge of what effects each of these players on this chart have. So let alone a good model on how they interact and in relation to these interactions and cardiac repolarization. So injecting the data of Gordine here, it's all pretty clear. Somatostatin, it knocks down the insulin, but also glucagon. Glucagon itself has effects on cardiac repolarization. And that is something I wanted to flag to you. The question as to whether glucagon effects may be beneficial has become a topic in clinical outcome studies of DPP-4s, GLP-1s, and SGLT2s. And I will come back to this. But if we deal with a healthy population, then of course we look at a regulatory mechanism that's normal. If we deal with patient populations, then we of course look at a model that is different. And I emphasize, I don't think we know anywhere near enough. Now here's another somatostatin agonist, Pasireotide. And this was studied for incretins, glucose, etc. And you can see the results for each of these entities on the slide. So insulin is knocked down, obviously. As a consequence of that, glucose rises. Glucagon is knocked down, GLP-1 is knocked down, and GIP is knocked down. So the last two, depending of course on the specificity in binding to somatostatin receptor subtypes, which obviously different somatostatin agonists have slightly different binding characteristics to subtypes. Now, here is the QTc study for Pasireotide. We have already seen the QT prolongation induced in healthy volunteers by octreotide, and we see the same here. And there's one thing, if you look at the top left panel, clearly the effect of Pasireotide in both doses, therapeutic and supertherapeutic, top the Moxi effect. On the bottom right, you see the concentration effect relationship of Moxifloxacin. You can see the slope, and if you look at the top right picture, I've essentially transposed the Moxi slope, and you can see the Pasireotide slope is somewhat flatter. It, in the time course analysis, clearly has a greater effect, but the relationship between concentration and QT effect is less clear. You would expect the slope to be steeper, not flatter. So nothing really helps us at the moment distinguishing hyperglycemia-induced QT prolongation from drug-induced QTc prolongation, because I think what we see here is really an effect on glucostasis with hyperglycemia and the QT prolongation that is induced by that. And I want to show you this example showing glucagon to raise three issues really. So the differences we see between patients and healthy people. We show here type 2 diabetes, but of course you need the exact same charts in a sense to look at effects in a healthy person to get some deeper understanding. There are various antidiabetic medicines which will affect just glucagon alone, let alone the whole regulatory mechanism differently. And finally, you can see on this slide very clearly that also your experiment matters hugely. So on the left side, you see a solid meal. On the right side, you see an oral glucose tolerance test. And this is simply an experimental situational difference. It's just the type of glucose that we are feeding. And the left side, the solid meal, you see the glucagon increase, which is what you also see in normal people, as opposed to on the right-hand side, where you simply give an intravenous glucose challenge, you don't see that. And of course, these studies are going to give you different answers, therefore. And these questions are not only of experimental relevance, as they're also quite relevant to clinical outcomes. Skellin in 2018 speculated that the better cardiovascular outcomes of GLP-1 and SGL2 compared to DPP-4 inhibition may be related to the observed increases in glucagon and insulin in the CANVAS, SUSTAIN-6, LEADER, EMPA-REG outcome studies. All of these studies show favorable outcomes, and they all also show increases in insulin and glucagon. Now, Pasireotide in 2019 rejected this, suggesting that insulin is also raised, and then citing some very outdated data on insulin, essentially making it the villain in the game. So he seems to accept that glucagon may have positive effects, and he points out that insulin is thought to have adverse effects. And that is, of course, something I do not agree with. I would suggest it's not insulin itself raising QTc. We've done studies investigating this. I think what increases the QTc interval length is the resistance to insulin in the type 2 diabetics. And that possibly the same mechanism is at work that I will show you, which is at work in type 1 diabetics, who of course are insulin deficient. Now this is data which is in the process of being published, but I've presented data of this kind many times. It's not new. A meal shortens the QTc interval compared to a fasted state in healthy people. The main contribution for this QTc shortening is a shortening of the J to T peak interval. And that is shown on the top right panel. So in normal people, JTP shortens, and as a consequence, the QTc interval shortens overall. We've conducted 2 studies and had 2 statistical groups grappling with the CE module. They both showed independently that glucose is connected to QTc prolongation, and C-peptide concentrations correlate with QTc shortening. We've hypothesized that C-peptide may be an active ligand, and that via an unknown, undiscovered receptor mechanism, that this might lead to this effect. Now, the search for this receptor is still ongoing, but it is yet to be identified. However, and here's the new bit, If we take C-peptide, that is released, of course, in equimolar amounts with insulin. Its connecting peptide holds together two strands of insulin and proinsulin. But when it is released to the bloodstream, the insulin disappears quickly, whereas the C-peptide has a much longer half-life. So if rather than speculating that C-peptide has a direct receptor effect, if we merely take C-peptide concentrations as a reflection of the total amount of insulin that is released by the pancreatic beta cells, then this could be an indication that the insulin is doing its job and is therefore shortening the QTc interval. But of course, because of its rapid disappearance, we can never really correlate it. What we have done, and that's published, is we've raised levels of insulin and we could see absolutely no trace of any relationship between the acute insulin concentration and the QTc interval. So it would be a different timing of effect, and it would essentially be a relationship we cannot capture in a concentration effect model. The key message I want to give you is, could it be the insulin rather than the connecting peptide that's leading to the QTc shortening? And just hold on to this idea for a moment. Now, this is a study which we've done recently, and it was inspired by the paper Gordon is published in 2007, which I've mentioned in my talk earlier. And briefly, what we've done is we recruited type 1 diabetic patients, 50-50 men and women. They went through a placebo day where essentially we just left them on their normal treatment. We induced hyperglycemia with a target level of 25 millimoles per liter. And then we had another study day where, on top of the hyperglycemia in the region of 25 millimoles per liter, we gave them an intravenous infusion of Moxifloxacin. And the purpose was to see the interaction between an ion channel block and hyperglycemia-induced QTc prolongation. The study was run like any other TQT study, ECG acquisition, etc. We used the combined oral intravenous glucose clamp, so 75% of the glucose was delivered orally, and we used an IV top-up to fine-tune the hyperglycemia to the target glucose level. And the glucose needed was the same on both hyperglycemia days, so with and without Moxifloxacin. What is interesting is that women needed about 100 grams to get to the concentrations we wanted, whereas men needed 160 grams, so 60% more. And the weight difference between those two is not that high. So there were other reasons why men needed more glucose in order to reach the hyperglycemic state we were targeting. And the reason why I think this occurred is because those groups differ in terms of the underlying insulin normal treatments, and I will discuss that in a moment. So the first study I've shown you the slides for QT shortening, healthy volunteer trial. They do have similar demographics, the diabetic group and that first group, except the first group, the healthy group, had fewer. On the left bottom panel, you see QTcF, and you can see the black line, which is the glucose concentration. And you can see that for the first hour, it's up-titrated stepwise to reach 25 millimole thereabout, and then we keep it there for 1 hour. So 1 hour up-titration, 1 hour of constant hyperglycemia. And you can see the QTc effect for males in blue and for females in red. If you look at the top right panel, then you see that the JT peak interval is prolonged. to about 15 milliseconds during the infusion. So where in a normal person GAT peak is shortened, in type 1 diabetics, in a state of hyperglycemia, it's prolonged. And if you look at the right bottom panel, then you see T peak to T end. And this interval is shortened by about 10 milliseconds in males during this infusion, whereas women do not show this effect. And so there appears to be some sex difference. Now, this is the day where we combined hyperglycemia with moxifloxacin infusion. And you can see that the glucose levels we achieve are almost identical to the hyperglycemia day 1. And again, on the left bottom panel, you see the black line showing the glucose and the prolongation for men and women, blue and red. And you can see that we're now approaching 20 milliseconds. So the two effects combined give you about 20 milliseconds QT prolongation overall. And if you look at the JTP interval, then that's prolonged to about 25 milliseconds during the infusion. And the right bottom panel, there's an interesting find here, because T peak to T end interval is again shortened by about 10 milliseconds in males during that infusion. So we speculate that this shortening we observe in males is truly something that is related to hyperglycemia, and only really at the last time point, at the 2-hour time point, might be affected by rising levels of moxifloxacin, moving this curve in the opposite direction. Now, women do not show this effect. Just briefly, the concentrations of moxifloxacin, we used a reduced dose of 300 milligrams and gave it intravenously, obviously as a safety measure, because we didn't know what the interactions were going to be. And as a consequence of that, in a normal oral moxifloxacin study, you would see Cmax concentrations of about 2.5, and we sat about 2.1 thereabout. So near enough, but slightly lower concentrations. Now, we know hyperglycemia is associated with increases in potassium and clinical hyperkalemia. We also know that insulin facilitates the uptake of potassium into the cell cytoplasm via the sodium-potassium ATPase. And the change in potassium we see here is tracing the change in glucose, which we don't show on this graph. And it amounts to about 0.5 millimole per liter in women, and it amounts to 0.75 in men, so about 50% more. Now, increases within the physiologic range were associated with QTcF shortening in patients with ion channel impairments, and that's a publication going back to 2003 by Etheridge. Now, we cannot quite reconcile these findings at the moment, but we're working on that. We randomized this study for sex, as we are interested in sex differences. And like on the previous slide, there were some subtle differences between sexes. If you look at the QTcF glucose slope for men, that is clearly somewhat flatter than that for women, which is shown on the right side. Hyperglycemia is shown in blue, and the hyperglycemia plus the moxifloxacin is shown in red. That's slightly confusing. I apologize. So the point is that the addition of moxi does not really change the slope, but the intercept slightly. And so these curves essentially are the slopes run in parallel. The study was randomized to balance sex differences. However, we noticed a confounding factor for which we had not accounted for. That was the patient's normal insulin regimen before entering the trial. Patients were either taking ultra-long with short-acting top-ups or long insulin preparations, as well as short short-acting insulin preparations only. And coincidentally, in this study, most women used insulin pumps and most men used a combination of a long and short-acting insulin injection injected as and when required. So when analyzing the QTcF allowing for insulin use, a very different picture from that looking purely at sex differences emerged. Now the glucose concentrations we saw don't differ between these groups of insulin users because, of course, we had uptitrated the glucose concentrations to our target 25 millimoles per liter, and we took as much glucose as was needed to achieve that. If we now look at the QTc results, then we see that in those three groups, i.e. ultra-long, long and short-acting insulins, the effects on QTcF differ quite significantly. So you had the least effects as a consequence of hyperglycemia in those using ultra-long preparations, a slightly greater QTc effect in those using long-acting insulins with short-acting top-ups, and you saw the greatest effects in those patients who took short-acting insulins, usually delivered by an insulin pump, which were mostly women in this study. So if we look at the effects of the short-acting insulin, that meant we washed them out of their insulin, and therefore they were truly insulin deficient, whereas the other patients presumably had some spillover insulin available, and that might well explain why these differences in QTc effects arise. Now, the worst group in this study clearly is those on short-acting insulins. They had, increases of QTcF of 25 milliseconds on hyperglycemia alone and around 35 in the combination of hyperglycemia and moxifloxacin use. And in this group, the individual increases went up to 60 milliseconds, so quite significant changes in QTcF. From this finding, I conclude that it is actually the absence of insulin that drives hyperglycemia, but most importantly, the QTc prolongation. Now, the importance in type 1 diabetes is, of course, that most diabetics experience longer or shorter whiles during which they're hyperglycemic. And you can see in this paper from Garg from 2004 that you look at excursions of 20 to 30% of the time. And depending on the type of the insulin people use, they may, during these times, be exposed to an extra risk. Now, outlook and summary. Before I close, I would like to make my thanks to my co-workers, peers and mentors. The two doctors who did most of the clinical work were Sam Cole and Helen Wibberley, and I think they did a fantastic job. They helped a lot. We had two statistical teams working on the concentration effect models, and I thank them. They did a lot of work. I thank Yvonne and Isabel, who are from the Regimen Research Institute, Dilshad Jumanov, who did all the data management and the ECG management, Klaus Graf, who was kind to measure all our QT subintervals using GE Medical's QT Guard Plus. And I would also, of course, thank John Kam, Atsushi Sugiyama, Krishna Prasad, Boris Menzelewski, because at different times, all of these people have made a contribution to this work. And of course, there's many others who have helped, to whom I'm very grateful. Let me conclude. We know hyperglycemia is associated with adverse clinical outcomes and QTc prolongation, and whether these two are independent or not, we simply do not know. Our work here shows that insulin deficiency drives QTc prolongation. So it is not hyperinsulinemia that drives QT prolongation and is likely to have adverse effects. It is merely present, but not the cause of QT prolongation. We do not know the Torsades points risk of these QTc prolongations in these patients. We must assume that prolonged hyperglycemia is associated with hyperkalemia, which then, of course, at the very end will lead to arrhythmias eventually. But what about the benign episodes these patients experience during the night when they are taking QT prolonging drugs? Our study clearly shows that if you add an ion channel block to the hyperglycemic QT prolongation, those two add up, they're cumulative. In regards to medicines interfering with glucostasis as target or off target, I suggest we consider follow-up to give greater credence to hyperglycemia and normal physiologic changes in the CSRC white paper dealing with these effects. And I'm really very keen to participate in the working group if one was forming. And finally, the Regimen Research Institute, as a not-for-profit organization, is dedicated to fund mechanistic clinical studies to help understand outcomes where the pathology and or drug effects are poorly understood. And with that in mind, we are embarking now on a study very similar to the one I've shown to you, where we will make investigations in type 2 diabetic patients, so to investigate whether it's really the insulin resistance that leads to the QTc changes we observe in type 2 diabetic patients. I thank you for your attention and can take questions. Thank you very much.